Good morning. Welcome to day 2 of the STS 56th annual meeting. I hope you enjoyed yourself last evening. We really had an extraordinary opportunity to share fellowship and new associations. We have another great day in store, but first, as a reminder, please silence your cell phones and other devices. In just a little while, you'll hear about 3 abstracts that have been designated as the Chamberlain Papers, considered by our program committee to be among the best submitted this year. But first, I'm thrilled to be able to share more with you about a highly anticipated next generation STS national database. Please watch the video.
You asked for innovation to meet your evolving practice needs. We heard you. We've spent the last 2 years creating the next generation STS national database, and it will deliver. One of the most highly respected, internationally recognized clinical outcomes databases in all of medicine will be better than ever. More than 4,300 surgeons around the world participate in the database. Data integrity meets innovation with interactive dashboards and real-time insights to advance quality improvement. Your new STS national database was developed with your input to anticipate your changing practice needs. It is a highly secure cloud-based platform that offers 24/7 access, data quality reports, missing variable reports, and acceleration of benchmarking for quality improvement. This powerful database was built on a 30-year legacy of credibility and has earned respect from all areas of healthcare, CMS for payment decisions, the FDA for device surveillance, and lawmakers for legislative decisions.
We now can predict, based upon nearly 8 million records, where patients are at risk for having problems. And patients, referring physicians, regulators, the government all can rely upon the STS database to be able to predict outcomes and improve them before surgery and after.
It's a new database for a new era of quality assessment from a trusted resource. It will be easier to use, save you time, and support practice improvement. During the first 6 months of 2020, you'll be able to see your data quickly aggregated, download charts and graphs, sort your data by procedure, date, outcomes, patient demographics, and compare your performance by time period and to national STS benchmarks.
One of the difficulties most programs have on distilling data and quality reports that have existed heretofore have been parsing out information from a large multi-page document. Now this will be graphically available, downloadable, and one can interact with that database. And in the very near future, we'll be able to look at time intervals and look at different subtypes of quality in the data, and then present that immediately in one's own monthly or bi-weekly quality meetings within your division or department.
Later this year, the database will feature a web-based data entry option for institutions that choose not to use a vendor, at least 30% fewer data variables in the adult cardiac surgery database, and supplemental data sets that leverage the CDC's National Death Index. This transformation is significant.
I am most excited to use the missing variable report. Now we have access to real-time reports, and that will eliminate a lot of frustration, and we will be able to get information to our physicians faster.
The new STS National Database is for you, giving you practice-changing data as you work toward what matters most: improved quality of care and patient outcomes. The database drives research and education, informs and influences public policy, and provides critical pathways for quality improvement. STS is uniquely positioned to provide these comprehensive resources for the specialty.
It's just amazing to imagine what a discussion will be like 20 years from now after we have the advantage of implementing all these new ways of doing things, the addition of technology, computers, machine learning, and artificial intelligence. This specialty will be a better specialty in the next decade. It will be better for patients, and it will be an example for other specialties in the healthcare industry to follow.
Learn more about your new STS database at sts.org/database. The new STS National Database. Trusted, transformed, real time.
Good morning, President Higgins, members and guests. I'm going to walk you through a little bit about what this next generation database is all about. Really, the overview is, I'll touch base very briefly on the goals for the database, the new functionality, the status update on what the last few years have come to here, and the 2020 phased implementation and some upcoming features. Really, the transitioning of the database really achieved a few things. One is to implement 24/7, 365 cloud-based platform with enhanced data security and fidelity, while at the same time reducing the burden of data collection by our end users, and at the same time expanding the functionality of the database for all of those that use the data set. Essentially, this is a 24/7 cloud-based platform that allows for continuous data harvest to decrease the time spent at each institution, then permitting interactive dashboard reporting to allow this real-time assessment of one's own data, initially unadjusted, and then immediately after this in risk-adjusted format to drill down for quality improvement, and allowing this real-time feedback for user-friendly quality reports. And coming in July of this year, we will have, at no additional fee to sites, the ability to upload directly to the cloud without a vendor, but also maintaining your vendor that can also be utilized in the same manner. And at this time, then reducing for the adult cardiac surgical database, reducing the data burden by a substantial amount. So breaking it down even further, the phase 1 rollout, which is occurring as we speak here, that there's a data submission uploader tool, new data quality reports, new dashboard reports, and most importantly, allowing MIPS compliance. In phase 2, which will occur between now and over the course of the spring, will then enhance the data reports with more analyzed functionality, and I'll touch base on that in a moment. And in phase 3, coming in the summer, we'll see the adult cardiac surgical database reduce its data burden by 34%, and allowing direct data entry into the cloud. So really, where have we gone? This is the journey that we've gone on. So from 2017, this started to truly evaluate proposals for a new interactive data platform. Earlier this year, in April or May, we'd selected IQVIA as our partner for the new data warehouse. And then from August to November of this year, we've transitioned 8 million patient records into the cloud. From November to December, the cloud format was activated, but in a cloud format to allow for user testing. And we've been beta testing it since the beginning of January, and we're poised for the launch that will be happening momentarily. At the same time, today we'll be beta testing the general thoracic surgical database with a launch anticipated shortly thereafter. And in early February, we'll be beta testing the congenital heart surgery database with a subsequent follow-up launch. So phase 1 includes right now the uploader functionality, missing variable report, data quality report, and dashboard reporting, initially as unadjusted site outcomes to STS benchmarks that are already established. In phase 2, that's immediately pending, will be enhanced database reporting. And this will be, once we have the initial harvest, we'll be able to do a bidirectional data exchange to provide risk-adjusted outcomes that'll be available on the dashboard, compared to STS risk-adjusted benchmarks, and allow for more interactivity for quality improvement. Now let me give you a sneak peek of what this would look like. So this is actually active data from the database, and this is a little video to show the functionality. This is O/E ratios, risk-adjusted data that's actually real data from the database, and one can adjust the time intervals as well as the scale to get more fidelity. This is a multi-year assessment of the data. And if you want to drill down even further on one area, you can actually move the time interval to a single year or the most recent year, and then actually access individual platforms of how this data is being presented, and then drill down even further if you want to adjust the scale, the numbers of patients involved, and any given outcome. And then after doing that, you can also then go back and do further assessments, not just on the data itself in one format, but then look at different operations. So this is mortality, for example. You can go to aortic valve replacement, mitral valve replacement, AVR CABG, and then if you would like then to follow, you can then drill down further on any given operation on the specific outcomes. So for example, this is an example of stroke for CABG, stroke for AVR, and you'll be able to look at different time points going back multiple years, but also drill down in the actual time period of interest. And then most importantly, be able to download these in PDF format or directly into a Microsoft PowerPoint presentation for presentation into your quality meetings. STS and IQVIA together have provided multiple resources to allow for support for our data managers, users, and surgeons. Active right now in the exhibit hall is the live data set ready for your use. Right as soon as you enter the exhibit hall, it's available right there, and you can see demonstrations. There's resource documentations on how-to videos, frequently asked questions, and live checklists, and then also vendor engagement with our existing vendors through STS and IQVIA. I have to thank several leaders in the data set that has brought us to this point. Donna McDonald, the chair of quality, Bill Seward, the associate director of the database, John Morris and his entire team from IQVIA, all the data managers that have helped us, and some of our physician leaders, David Wormuth from informatics, and Felix Fernandez, the chair of the workforce. These individuals and many, many, many more, Carol Crone, of course, from the database, have dedicated hours upon hours to get us to this point, including active webinars, of which now total 20 webinars that reaching over 4,500 data managers over the course of the last 3 months. Of course, the database will be ready for your questions at this contact information, and hopefully we'll now enter into this new era of your database for the specialty, trusted, transformed in real time. Thank you for your attention.
Thank you, Dr. Badwar. Exciting times for us at the STS, and I hope you'll feel the energy in the room. I hope you're as excited as we are about this new database. It's finally here. And with your continued input and new database enhancements, we can gain more additional features and feature them during the year as this evolves to help support our specialty. The database provides the foundation for the Society's ability to serve the profession, and I'm hopeful that the video demonstrates that we are focused on research and education as well at this meeting. It informs and influences public policy and provides critical pathways for quality improvement. STS is uniquely positioned to deliver these comprehensive resources for the specialty, and hope that you'll take full advantage of them in the future. I want to, a personal demonstration of the dashboards and other practice-changing features are available in the STS booth in the exhibit hall, and encourage you to partake in those activities. At this time, I'd like to welcome STS Secretary Joe Savick to the stage as we introduce the Chamberlain Papers. And now it's my great honor to introduce the J. Maxwell Chamberlain Memorial Papers. Dr. Chamberlain has been described as a catalyst of the society. Although he was never STS president, he articulated the vision that helped make this society and all it does a reality. This year, we've selected 3 outstanding selections for presentation. The first is the J. Maxwell Chamberlain Memorial Paper for Adult Cardiac Surgery by Dr. Donald Lukowski from Michigan Medicine, who will present evaluating the role of failure to rescue on cardiac mortality after cardiac surgery and national experience. Dr. Lukowski.
Hey, well, congratulations. Well done. Thank you.
Thank you, Drs. Higgins and Sabick. I'm honored to be presenting on behalf of my colleagues the Adult Cardiac Surgery J. Maxwell Chamberlain Memorial Paper titled Evaluating the Role of Failure to Rescue on Mortality After Cardiac Surgery, a Multi-Collaborative Experience. I have the following disclosures. Failure to rescue is defined as death among patients developing a postoperative complication, with higher failure to rescue rates signifying worse outcomes. Failure to rescue is thought to be driven more by hospital and unit level practices and resource availability, as well as a failure to recognize and address complications rather than patient risk alone. With this in mind, failure to rescue is an established quality measure, and hospital-based rates are now publicly reported. Prior investigators have reported the role of failure to rescue in helping to explain hospital mortality differences. Ghaffari used Medicare claims to evaluate the role of failure to rescue and complications in explaining mortality differences for inpatient procedures. Complications were broadly defined based on billing data. Complication rates were similar across hospital mortality quintiles, while failure to rescue rates were higher at high quintile hospitals. Otherwise stated, a patient's likelihood for surviving from a complication was dependent upon where they actually had their procedure. More recently, Edwards used national STS data to evaluate failure to rescue among isolated CABG patients. In contrast to Ghaffari, Edwards used clinical data to more narrowly define major complications. Nonetheless, a similar pattern persisted. A patient's likelihood of surviving from a complication differed across hospitals. Additional questions remain unanswered, including whether or not these relationships are consistent across procedure type, and importantly, whether these patterns are dependent upon what complications are included in the failure to rescue measure. With this in mind, my colleagues and I evaluated the impact of complications in failure to rescue on mortality following cardiac surgery using data from the IMPROVE network. The IMPROVE network is a voluntary consortium of cardiac surgery quality collaboratives representing nearly 10% of all cardiac surgical programs in North America. We analyzed STS data from 112,589 CABG and/or valve procedures from 90 centers across 6 of our quality collaboratives. We created terciles of hospital observed to expected mortality rates. We then evaluated the following outcomes: operative mortality, complications, and failure to rescue. We further stratified complications into STS major, seen here in red, and all, including any of 19 postoperative complications. In this presentation, we report findings from the following analyses. First, we calculated an expected failure to rescue rate using baseline patient risk factors, the type of complication, and the hospital in which a patient had their operation. Second, we evaluated differences in complication rates, both defined broadly and narrowly, operative mortality and failure to rescue across mortality terciles. Third, we evaluated whether the risk of failure to rescue differed by the type of complication, and then further explored differences across mortality terciles. Last, we correlated observed and failure to rescue rates at the hospital level, stratified again by the severity of the complication. Failure to rescue rates differed as a function of whether we defined it broadly to include 19 complications or narrowly to include only the most significant 5 STS major complication types. When defined broadly, 39% of patients developed a complication. The failure to rescue rate in this population was 6%, but varied between 1 to 14% across hospitals. When defined narrowly, only 12% of patients developed a postoperative complication. Nonetheless, far more of these patients died after developing a major complication. The failure to rescue rate in this population was 13%, yet varied between 3 to 29% across hospitals. Thus, failure to rescue rates increase as a function of the severity of the complication. Patients at low and high mortality tertile hospitals were qualitatively similar with regard to their preoperative risk. Patients at high mortality tertile hospitals were more likely to have longer intubation times and experience operative mortality. Cabbage valve procedures independently predicted failure to rescue in multivariable analysis, and only when failure to rescue was defined to include all 19 complications. Next, we compared outcomes across low versus high mortality tertile hospitals. The x-axis shows the outcome measure, and the y-axis the percent of patients experiencing that complication. The gray bar represents patients in the lowest tertile hospitals, while the black bar includes those in the highest tertile hospitals. There were no significant differences in all complications across mortality tertiles, yet patients at high tertile hospitals had slightly higher major complication rates. Operative mortality by definition was greatest at high tertile hospitals. Failure to rescue rates were greater at high tertile hospitals. Otherwise stated, patients developing complications, whether defined broadly or narrowly, were more likely to die at high tertile hospitals. We also found that failure to rescue rates varied widely across complication type. Complications with the highest associated failure to rescue rates included multi-system organ failure, cardiac arrest, and dialysis. Complications with the lowest associated failure to rescue rates included atrial fibrillation, permanent pacemaker, and surgical site infection. Complications having the highest variability across low, seen in gray, versus high, seen in black, mortality tertile hospitals included cardiac arrest, aortic dissection, and multi-system organ failure. Last, we evaluated differences in hospital observed and expected failure to rescue rates. As a reminder, expected failure to rescue rates were estimated using patient risk factors, the type of complication, and the hospital in which the patient had their operation. Expected rates are on the x-axis and observed rates on the y-axis. Hospitals above the dotted line perform worse than expected, meaning they have more deaths among patients who experience complications than would otherwise be expected based on STS data alone. Hospital observed and expected failure to rescue rates were correlated, suggesting that a hospital's ability to rescue a patient is explained in large part by existing STS data. However, this relationship was remarkably weaker for major complications, where only 20% of the variability in hospital failure to rescue rates is explained using STS existing data. We hypothesized that, among other things, hospitals with higher nurse-to-staff patient ratios and hospital or unit-level resources may be more successful in rescuing patients from these more severe complications. In this large multi-collaborative experience, differences in hospital operative mortality were attributed to failure to rescue. Failure to rescue rates were higher for patients in high mortality tertile hospitals. In addition, the ability to rescue patients differed by complication type and across tertiles. Hospital observed and expected failure to rescue rates were correlated, although this relationship was weaker for patients experiencing major complications. These findings further our understanding of failure to rescue and importantly highlight the importance of identifying and then disseminating optimal recovery practices. Thank you for the distinct honor to share our work with this society. Thank you.
Thank you, Dr. Lukowski. The discussant for this paper will be Dr. Rakesh Arora from Winnipeg.
President Higgins, Dr. Savick, I would like to thank the Society for the privilege to be the discussant for this important paper. I'd also like to thank Dr. Lukowski for providing me with a draft of this manuscript well in advance so I could review it in detail. To restate, failure to rescue, or FTR, is defined as a death that occurs following a treatable complication and is increasingly recognized as a quality indicator of significant value. As compared to operative mortality alone, failure to rescue is thought to provide additional insights into the overall performance of a healthcare team and their ability to successfully treat a postoperative complication. Dr. Lukoski and colleagues have leveraged an impressive data set of over 112,000 patients within the improved network to gain a deeper understanding of the rates and impact of failure to rescue following cardiac surgery. They've reported that approximately 1/3 of patients experience a complication following their index procedure, and this rate was consistent regardless if a center was either a high or a lower performing site. If a complication did occur, significant inter-center variability in mortality was observed, and this was driven by differences in failure to rescue. Most notably, if a patient had a catastrophic complication such as multi-organ system failure, cardiac arrest, or dialysis-dependent renal failure. It can be reasoned, however, that not all complications are equally treatable, nor would they necessarily occur in isolation of one another. With this in consideration, and in conjunction with the other findings you presented, I'm interested if the authors can provide additional insights on these two issues. Firstly, did patients with concomitant complications, whereby a patient suffered 2 or more complications, experience higher FTR rates than compared to those only experienced 1? Similarly, by combining all the complications into a composite outcome, could a center that experiences higher rates of untreatable or irreversible complications have a higher FTR rate versus those that do not? Secondly, there were some centers some centers that were good at managing certain complications and perhaps not so good as managing other ones. For example, they were good at treating sternal infection, but not so good at treating multi-system organ failure. Further to this, was an individual center's FTR performance consistent, or was there intra-center variability over the period of study? For example, could a center go from a low to a high-performing center, or vice versa? In summary, this thought-provoking paper further establishes FTR as a valuable quality indicator that may help us understand inter-center variability. This study, along with the ongoing efforts of our society in the fields of cardiovascular, thoracic, and enhancing recovery after surgery, highlights the need for interdisciplinary attention to the processes that involve the entire patient journey. I would like to congratulate Dr. Lukoski and the Improved Network again on their contributions to the field, and once again, thank you to the Society for this privilege.
Dr. Lukoski, you had some comments?
Thank you, Dr. Roy. I appreciate your careful review of the manuscript and your insightful comments. Even within our large experience, it's unlikely that we'll be able to actually look at every single possible combination of complication and the role on rescuing patients from that complication. Our crude findings confirm your point, however, that not all complications are equally challenging to perhaps both recognize and manage and prevent into the escalation of death during the patient's hospital stay. Complications in our analysis that were most likely associated with higher failure to rescue rates are interestingly also the most, at times, infrequent, suggesting perhaps that high-performing hospitals may have better resources and availability to identify a complication and bring requisite resources to prevent that complication from leading to death. Interestingly also, those complications that were more likely associated with failure to rescue also had the most variability across mortality tertile hospitals, further supporting the point I just made. Reasons for this finding are yet unanswered, but we feel that our network of quality collaborators are well situated to address this point. To go back to your point related to whether or not more complications are associated with worse outcomes, our analysis did actually find that to be the case, that there was a significant dose-response relationship between the volume of complications and mortality, irrespective of whether or not we limit the definition of failure to rescue to major complications or relax those to be associated with any of 19 postoperative complications. While our modeling did account for hospital, evaluating these changes over time are likely foster for further analysis. Thank you so much.
Are there any questions from the floor? There are microphones in the center of the hall. I would ask anyone who does ask a question to please identify themselves.
Okay, great. Well, great. Thank you, Dr. Lukoski. We look forward to your future advances in this work. Thank you very much.
Appreciate it.
I'd like now to introduce Dr. Inderpal Sarkaria from the University of Pittsburgh Medical Center, who will present the Chamberlain paper for general thoracic surgery. His paper is Multi-Institutional Phase 2 Clinical Trial of Intraoperative Molecular Imaging on Non-Small Cell Lung Cancer.
Thank you, Dr. Higgins. Thank you, Dr. Sabik. And thank you to the Society for the humbling privilege to present this work on behalf of the co-investigators. This is the multi-institutional phase 2 clinical trial of intraoperative molecular imaging of non-small cell lung cancer. There are no relevant disclosures for the individual investigators. The study was funded by the company through individual contracts with the institutions. There are over 200,000 new lung cancer cases per year in the U.S., and surgery remains the standard of care for early-stage lung cancer. The goals of surgery remain, as always, complete resection to obtain negative margins, adequate staging by identifying occult disease at the time of surgery and appropriate lymphadenectomy, and more frequently, parenchymal sparing operations when possible by segmentectomy and sometimes wedge resection. There are several challenges, however, that may not allow us to achieve these goals in every case. It is reported that up to 17% of cases may have additional occult tumors not identified on preoperative scans. Localization of the primary tumor may be challenging, especially in the era of increasing numbers of minimally invasive procedures, including robotic procedures. And margin assessment at the time of surgery may not be optimal with frozen section, and just observation and an 8% positive margin rate is identified on post-operative final pathology at a time when we can no longer intervene at the time of the case. Intraoperative molecular imaging is a technology that uses a tracer, which binds to a receptor, with a linker and then a dye that fluoresces when excited by laser and then emits a wavelength of light that can be picked up by dedicated cameras. OTL-38 is a novel molecular imaging agent that leverages a folate receptor alpha tracer, a linker, and a dye. It is given intravenously, not intratumorally, as a systemic drug. It is highly specific to lung adenocarcinoma, has very high binding affinity for lung adenocarcinoma, and is stable in that binding, and uses a dedicated near-infrared camera system in order to identify the emitted fluorescence. In essence, the tumor glows. The simple question for the phase 2 trial was, can intraoperative molecular imaging with OTL-38 improve the quality of lung cancer operations? Phase 2 trial design, this was a multi-center trial in the US and with one international center as well. All IRB approvals were at the individual institutions or with central IRB. The enrollment criteria were quite simple. A high-quality CT scan within 6 weeks of surgery, a 1 millimeter cut, pulmonary nodule had to be identified, and the patient had to be scheduled for curative resection. There was no age restriction other than less than 18 years old. The endpoint was clinically significant events, those events in which the technology, beyond the standard of care, was the only means by which either identification of occult synchronous lesions occurred, localization of the primary tumor, and as well as identification of positive margins that then changed the course of the operation. Again, these are events in which the technology was needed to identify the tumors, occult tumors, and to identify positive margin. 0.025 milligrams per kilogram of the drug was infused 2 to 6 hours prior to surgery. There were 3 phases of the trial for the surgeon to perform: lung inspection, and these were all comparisons where first the standard of care was performed and then the molecular imaging. Lung inspection, looking for identification of synchronous lesions; tumor resection, identifying the primary lesion and appropriately resecting it; and the specimen check. After resection, taking the specimen to the back table and assessing the margins both by observation and then by molecular imaging. Data points are as listed. What does it look like? A picture's worth 1,000 words. This is one of our study patients. This was a patient that was infused, again, systemically with the drug 2 to 6 hours prior to the operation. Taken to the operating room, you see on the left side of your screen is the natural white light image with the usual camera, and the molecular imaging on the right with the molecular imaging superimposed. The tumor is not apparent on the white light image. It is clearly apparent with the molecular imaging. This was a proven adenocarcinoma on final pathology. This is another example of an occult synchronous lesion. You may be able to make out a small tumor there under white light, but it is clearly observable with the molecular imaging here. This is an example of the margin assessment. This is a close margin, no doubt, but under white light, is it clear that the tumor is at the staple line? With the molecular imaging, if you see that glow at the staple line, that is a positive margin. Here, in contradistinction, is a clearly negative margin. Under white light, you don't see anything. It's very difficult to assess that margin. With the molecular imaging, you see the tumor clearly within the parenchyma, well away from the staple line. For all of the patients in this particular study, if that distance was greater than 5 millimeters from the margin, none of those ended up being a positive margin on final pathology. For the purposes of this study, any tumor within 5 millimeters of the staple line was considered a positive margin. All specimens were pathologically verified, both for histology but also for expression of folate receptor alpha. Results: there were 110 patients enrolled in the study. After exclusions, 92 patients were ultimately analyzed. Mean age was 67 years, the majority were female, and just under 50% had a preoperative diagnosis. About 50% diagnosis was made at the time of surgery, and often with the molecular imaging technology, given that it is highly specific to adenocarcinoma. The mean preoperative tumor size based on preoperative CT scans was 2.3 centimeters. This appears to be a very safe drug. The most common drug toxicity with infusion was nausea and a mild hypersensitivity reaction, which was often treated with Benadryl. There were 2 grade 3 toxicities with infusion of the drug: chest pain in a patient that had a negative EKG and troponins, as well as 1 transient O2 desaturation, both of which stopped immediately after the infusion was held. Those patients had no long-term sequelae. There were no imaging-related events. 64 patients underwent wedge resection, 16 segmentectomies, 43 lobectomies, and 64 of these tumors were adenocarcinomas. This is a summary of the clinically significant events. Again, those patients in which intramolecular imaging was the only means by which either a synchronous nodule was identified in 9 patients, the primary tumor could be localized in 11 patients, and the margin identified as positive when it could not otherwise be determined with routine methods in 9 patients. So in total, 24 patients, or 26% of the patients in the cohort, had a clinically significant event in which the technology changed the course of the operation for that surgeon. To look at a little bit deeper on this busier slide, I wanted to first show you the overview. 24 nodules, so 8% of patients were identified by IMI or the molecular imaging alone. 9 of those 24 nodules were additional cancers. So in 8% of patients, we were identifying additional cancers. There were 16 false positives, including AAH. We did not include adenomatous hyperplasia as a positive finding of adenocarcinoma. And in 8% of patients, there was upstaging due to the IMI or the molecular imaging alone. As far as tumor localization is concerned, 14% of patients had tumors that could not be localized by standard methods. 11 of those 13 patients were identified with the molecular imaging. 2 patients who could not be determined by either method did require lobectomy for very deep lesions. And 6 of 11 of these patients, 55% of these, were GGOs. This technology appears to work very well for GGOs. Margin assessment: 16 close margins were identified as less than 5 millimeters. 9 of those 16 were truly positive on final pathology. And in 9 patients, or 9% of patients as well, 8 patients, these close margins were only identified by the intramolecular imaging. Again, 26% of patients had a change in their course due to the technology. In conclusion, intraoperative molecular imaging with OTL-38 can potentially improve quality of lung cancer resections in 24% of patients through improved identification of occult tumors, facilitating localization of primary tumors, improving real-time intraoperative margins. Therefore, this technology has the potential to improve recurrence and survival outcomes for these patients. A phase 3 multi-institutional randomized clinical trial is currently in planning and in launch preparation. Again, thank you very much for the humble privilege of presenting on behalf of my investigators.
Thank you.
Co-investigators.
Thank you, Dr. Sarkaria, for that fantastic presentation. The discussant for this paper will be Dr. Natalie Liu from Stanford.
Good morning. Thank you to President Higgins and the Society of Thoracic Surgeons for inviting me to discuss this presentation. Congratulations to Dr. Sarkaria, Dr. Singhal, and the authors of this outstanding study. Molecular imaging has great potential in surgical oncology because vision and palpation alone are often not accurate enough to distinguish tumor from normal tissue intraoperatively. It will have a greater role in thoracic surgery as more small nodules and ground glass opacities are found incidentally or on screening CT scans, as more sublobar resections are being performed, and with the increasing use of minimally invasive surgery. Dr. Singal has pioneered the field of molecular imaging in thoracic surgery. It is remarkable to see his efforts over the past decade, taking an idea from the lab to a clinical trial and now to a multi-center study. The contrast agent used in this study, OTL-38, is targeted to a folate receptor to improve specificity and used a near-infrared dye to improve tissue penetration. Previously studied contrast agents, such as high-dose indocyanine green and EC17, only had one of two important properties. The development of this agent will likely push this technology closer to becoming a part of routine clinical care. I have 3 questions for the authors. My first question is about the lung inspection phase of the operation. In this study, you found additional malignancy outside of the planned resection in 8% of patients. These nodules were not found using preoperative imaging or intraoperative white light examination or palpation. Previous studies by Dr. Singal have shown a similar rate of occult nodules and malignancies. However, it seems unbelievable that so many patients had occult tumors given the detail of our current CT scans. How large were these occult nodules, and did you review the preoperative CT scans to see if they were there in retrospect? My second question is about the depth of imaging, since limited depth of penetration is a known limitation of molecular imaging. How deep were the nodules identified by molecular imaging? Does the depth depend on the size of the nodule? For example, can larger nodules be identified at greater depth? My third question is about the learning curve. Several of the surgeons in this study were new to molecular imaging, and the primary difficulty is usually interpretation of the background signal. In fact, here, the tumor to background ratio is often hard to determine. What causes any background signal, and what lessons were learned to distinguish it from tumors? Do you think this technology can be easily taught to surgeons who are not experts in the field? Congratulations again to the authors on their exciting findings. We look forward to future studies of this contrast agent and the development of molecular imaging in thoracic surgery. Thank you.
Thank you.
Thank you, Dr. Su, for those very important questions. A couple comments. So as far as the molecular imaging itself, we did mention that the preoperative size of the known nodules was about 2.3 centimeters. The nodules that were found by intraoperative molecular imaging alone were on the order of 0.8 centimeters. So quite small. And did we retrospectively review the CT scans in order to identify them? We did in some cases, but in truth, that retrospective look at a CAT scan after you've been to the OR, many of us dictate simply an additional nodule is found in the right lower lobe. It's quite hard to put those two together to see if that nodule was truly there and is the index lesion that you identified. I might also suggest that for the practical purposes, this is a real-world practical situation. You're in the OR. You are the attending surgeon who's already looked at that CAT scan. If you miss the nodule, you miss the nodule. And if the technology can help you identify it at the time of surgery, that's the adjunct. It's safe, it's augmenting your ability to find these nodules, and still allows you to do the routine operation you would still do. So it's an important question, but for the practical purposes of operating, I would suggest that the 5 experienced surgeons in this trial looked at their own CT scans and still missed those small nodules and identified them at the time of surgery. As far as how deep into the tissue can we see? That is really a function of the concentration of the drug in the tumor, which is directly related to the amount of tumor burden or tumor cells. So in a tumor with a large amount of necrosis, you may not have as much fluorescence. But if you have a solid tumor with a high burden of tumor cells, our experience is that you may be able to see as deep as 2 centimeters in collapsed atelectatic lungs. So the true depth is actually a bit more than that in the expanded lung. That's probably the extent of the technology. GGOs work very well. In our sub-analysis afterwards, we did look at the brightness of these tumors, and GGOs were amongst the brightest because they do have a high concentration of tumor cells. The limitation is certainly going to be the tumors that do not have the higher concentrations of tumor cells that are deeper within the parenchyma, and this just simply may not be the technology to identify those nodules ultimately, but certainly advances in the technology over time may overcome those limitations. As far as the learning curve and the signal-to-noise ratio, very important questions. You may have noticed in some of the videos that there's reflectance. You're seeing fluorescence in areas other than the tumor. That's really a function of the camera systems at this point and the state of the technology. So the technology depends on a laser which emits from that camera. It reflects off of everything. It reflects off of periosteum. It can reflect off of macrophages and other things. So it's not a perfect technology, but the learning curve is certainly surpassable. All surgeons in the trial did about 6 cases and certainly 10 cases before everyone was quite comfortable with the technology. So yes, I think it can be learned, but it is a new technology, and just like any technology, it takes some experience. How strong do you emit the laser? Because you can control these things for many of these camera systems. How much do you move? How do you triangulate? How do you manipulate the tissue in order to be sure that you're seeing a lesion and not a reflected area? But I do think the future improvements in the technology based on camera improvements and filters will surpass those signal-to-noise issues in the future. I do think it's teachable, and I was able to learn it, so I think just about anyone can learn it.
We have a few minutes for discussion from the floor. Again, I please ask that you identify yourself.
Joe Schrager from Stanford. Fantastic work. Your senior author really should be congratulated for the doggedness, with which he's pursued this technology, which is amazing. 2 questions. One on that signal-to-noise ratio issue. How many false positives were there where actually somebody saw a signal and then did a resection and there was nothing there, which increasing the length of the operation, et cetera?
I don't know that there were true false. There was always a lesion there, from my understanding of the data, but I would want to go back and verify that for you. There were certainly a number that were not tumor. What I did show you were 24 lesions removed, 9 of which were actually tumor. So a number of granulomas, AAH. AAH may be very similar to what you're saying, not truly a tumor, not truly tissue, but it certainly fluoresces, and other lesions, and including 1 microcoil that was found to fluoresce. Okay. But as far as true false positives with no tumor or no lesion within the actual tissue, I'll have to verify that for you. I do not believe there were any cases of that.
Okay. And then the other thing is, even when there is a, quote, invasive cancer identified, invasive cancers that were pure GGOs radiographically have a very benign progression, if any. Some of them might even be pseudotumors. So I wonder how many of the additional lesions identified were pure GGOs.
Pure GGO, we classified them as GGO. I don't know that we put a pure GGO, and I don't know the experience of everyone, but in most cases there's usually an invasive component of just about any GGO as well. But it brings up a fantastic question of the utility of the technology. This was a feasibility trial, not necessarily a trial to determine if every one of these nodules should be removed. It's can the technology help you identify it and augment your ability to do it. The decision to remove a nodule, to go to surgery, perform what you believe is the appropriate operation is up to the individual surgeon. The technology can help you augment that, but the technology cannot dictate that for you.
Time for 2 more brief questions. Please identify yourself.
Shumin Wogu, Roswell Park, Buffalo, New York. Congratulations on an excellent paper. I have 2 questions. One is about the possibility of lymph node assessment with this technology. And my second question is about the ability to differentiate between malignancy and inflammation, which is the major limitation in FDG that we use for our PET scans.
Yes, I'll address the second question first. Other fluorophores, such as ICG, do get taken up equally well with inflammatory lesions. For OTL, I would say that the primary confounder is probably granulomas. We do know that macrophages take up this compound as well, and that also is related to the issue with lymph nodes. The lymph nodes, once that compound is accumulated in the tumor, we do believe there is some passive movement to the lymph nodes, so we are not necessarily seeing a positive metastatic lymph node. There were positives, but there were a fair number of false positives in the lymph node assessment. So at this time, I would say you are probably seeing what we think is the sentinel node, or the first draining lymph node from that tumor. But whether it can predict positivity at this point, there's going to be a high false positive rate with lymph nodes. And I'm sorry, your second question, yes, inflammation and granulomas are some of the lesions that will also take up the compound.
Great. I think we have time for one more question, please.
Edward Hong, St. Petersburg, Florida. This is laser, so any concern for eye damage, and do you need safety protection? And secondly, squamous cells, all of these were adenos. Does it pick up squames?
This compound is highly specific to adenocarcinoma, which expresses folate receptor alpha at a magnitude 10,000 times more than most other cell tissues or tissues. So no, it does not work in squamous cell. It does not work in any neuroendocrine tumors. It is highly specific to adenocarcinoma, which is also part of its strength, because you will be making a diagnosis of adenocarcinoma just based on the fact that it's glowing without histological assessment is one potential avenue of this type of technology. And I'm sorry, your second question was regarding whether it works in squamous cells?
No, because it's laser.
Laser, yes, thank you. I never wore glasses. I don't believe the technology. I didn't try to shine it right in my eye either. But the it's minimally invasive. It's a routine light microscope. There's no recommendation to have to wear safety glasses other than the routine glasses we would wear in the OR. So unlike the YAG laser or the ND YAG, it's not the strength of that type of laser.
Thank you.
Great. Thank you very much, Dr. Sakaria. Look forward to your future work in this area. Thank you very much.
Thank you.
The final Chamberlain paper on congenital heart surgery will be given this year by Dr. Jennifer Nelson from Nemours Children's Hospital in Orlando. Her paper is National Landscape of Aortic Valve Replacement in Young and Middle-Aged Adults, clarifying the current and potential role for TAVR.
Good luck. Thank you. Thank you, President Higgins, Secretary Sabick. And on behalf of my co-investigators, thank you to the Society for the distinct honor of presenting this year's Chamberlain paper for congenital heart surgery. I have no disclosures. Aortic valve replacement is a commonly performed operation among young and middle-aged adults. Within this age group, there is a growing population of patients with congenital heart disease who often require repeat valve operations in a lifetime. But in the context of recent guideline modifications and expanded indications for transcatheter valves, the landscape of aortic valve replacement in adults is shifting. Given these developments, it is important to understand clinical outcomes by valve type in the young and middle-aged population, as current practice patterns and early outcomes for these age groups are unknown. Therefore, we aim to describe valve utilization and early outcomes by valve type for adults less than 55 years of age, including the subgroup of congenital heart disease patients. To accomplish this aim, we designed this study to capture all AVRs performed between 2013 and 2018 that were recorded in either the STS Adult Cardiac Surgery Database or the Congenital Heart Surgery Database. Deduplication, followed by extensive variable mapping, was used to merge data sets and data versions using similar variables when feasible. Our outcomes were 30-day mortality and a composite measure of morbidity that included renal failure, persistent neurological deficit, reoperation, and readmission within 30 days. Congenital patients comprised 16% of the overall cohort. This subgroup was defined by having a case record in the CHSD, history of a prior congenital cardiac operation, congenital valve disease as the indication for AVR, or concomitant congenital procedure. Standard statistical methods were used to assess outcomes using univariable comparisons and multivariable regression analyses. Women formed the minority of this cohort. When the congenital and non-congenital groups were compared, several important differences emerged.
Most notably, the congenital patients were younger and had a significantly higher rate of prior sternotomy and prior aortic valve replacement or repair. STS-defined risk factors for the overall cohort are presented here, including the proportion of patients with active endocarditis, moderate to severe chronic lung disease, and dialysis or shock at the time of AVR. When the congenital and non-congenital groups were compared, the congenital patients had a similar distribution, but lower rates of measured risk factors. Overall, pure AI was the most common type of aortic valve dysfunction. In the congenital subgroup, valvar AS was most common. Other valve dysfunction included subvalvar, supravalvar, and multi-level obstruction. Overall, bioprosthetic valves were the most commonly implanted type, followed closely by mechanical valves. TAVR, homographs, autographs, and Ozaki valves together accounted for only 3% of aortic valve replacements in this population. In the congenital group, mechanical valves were used most commonly, and autographs alone accounted for 3% of AVRs. There were 39 total TAVRs performed for the congenital patients over this study period. Valve use over time is shown here for the years where 12 complete months of data were available. Bioprosthetic valve use increased, while mechanical valve use remained relatively stable. TAVR utilization over the study period increased as well. 46% of this cohort had an isolated AVR, 12% had concomitant CABG, and 5.5% underwent annular enlargement at the time of AVR. The overall early mortality rate for the entire cohort was 3.6%. This figure shows 30-day mortality by valve type. The highest mortality was associated with homographs, and the lowest mortality was associated with autographs. TAVR mortality was similar to that of bioprosthetic SAVR. In order to facilitate further comparisons between SAVR and TAVR, we elected to present results for isolated AVR as well as the congenital subgroup. As expected, when all AVRs were compared to isolated AVRs had a lower 30-day mortality and lower rates of morbidity. When congenital patients were compared with non-congenital patients for the same outcomes, a similar pattern was noted for mortality and morbidity. Although among the TAVR patients, morbidity for congenital patients was higher than among non-congenital patients. This table displays multivariable risk factors for mortality. Notably, non-mechanical valve types were associated with a 1.2-fold increase in mortality compared to all other valve types, including TAVR. Among the multivariable risk factors for our composite morbidity outcome, both bioprosthetic valve type and larger implanted valve size were protective. Interestingly, use of a homograph valve was also protective after adjustment for other factors. This study was unable to assess reasons for valve selection or patient eligibility for particular valve types. Also, several important AVR endpoints were not assessed. In conclusion, valve utilization is evolving. The majority of young and middle-aged adults receive bioprosthetic valves, and bioprosthetic valve use is increasing. TAVR use in this population is rare, but also increasing. Our data suggests that the probability of death is lowest for mechanical valves. However, the risk for morbidity was lowest for bioprosthetic and homograph valves, potentially validating our current surgical strategies utilizing homographs in salvage or endocarditis situations. Congenital patients are unique but challenging to triage because certain characteristics favored TAVR while others cautioned against it. In this population, a prospective trial is needed to refine optimal patient selection and match patients to the most appropriate valve type. In the meantime, ongoing harmonization of variables across STS databases, establishing clear criteria to define adult congenital heart disease, and studying center-level characteristics, including case volume and experience, will be valuable efforts. Thank you. I'd like to acknowledge the participant user file program and my co-authors for their tremendous contributions to this project. Thank you for the privilege of the podium.
Thank you, Dr. Nelson, for that extraordinary paper. The discussion will be Dr. Emil Basha from New York.
Thank you very much. Excellent job, Dr. Nelson, with this presentation. This is actually an important subject because there's not much data known about this. The use, the real-time results with aortic valve replacements in this patient population of young adults. There's also no doubt that TAVR has been a disruptive force in the congenital arena as well. And so thank you for trying to pinpoint the exact role of TAVR in this patient population. I have 4 questions for you. The first one centers on TAVR. You showed that the TAVR mortality was around 2.9%. We know from the partner trial that the TAVR mortality was around 1%. The SAVR mortality was 1.8% in your data. Do you have any good explanations why? And I'm going to ask questions, maybe you can answer, and then I'll ask a second question.
Well, thank you for that very important question. I think, first and foremost, it's important to point out that the partner trial was conducted in a highly selected population where bicuspid aortic valves were excluded. In this study, which was not selected, there are other risk factors that could come into play, as well as factors that were not accurately assessed or measured in the partner trial. It is also true that we were unable to collect reasons for valve selection, and it's plausible that TAVR was selected due to patient factors. For example, the perception that patients were perhaps sicker. When we looked at the risk factors for isolated TAVR and SAVR patients in this study, TAVR recipients across the board did have a higher prevalence of known risk factors such as dialysis and greater than mild chronic lung disease. We also did not collect procedural factors. I think it's also important to point out that our study spans the era over which there's been development and improvements in the technology related to TAVR devices. For instance, the progression of the generations of devices that are now available, and it's possible that our results just capture an average sort of the experiences of the first, second, and third generation devices.
So having said all that and done all this work, can you give us your opinion about the role of TAVR in this specific patient population, that is young adults between 18 and 55 years old?
Thank you. I think when we look at the options, understanding that for a Ross operation is possible to virtually restore a patient to their normal life expectancy curve, that remains still an excellent option for patients in general younger than perhaps 40 years of age. There's also good evidence from this study and several others to suggest that for patients younger than 55, there's a survival advantage with mechanical valves. And as new agents for anticoagulation are being studied, I think we can reasonably expect safer alternatives to Coumadin in the not-so-distant future. And that said, I think there are important lifestyle considerations to factor into valve choice as well. Some new data are coming soon from the Cleveland Clinic that can probably speak better to the questions of durability of bioprosthetic SAVR in younger adults that we were not able to answer in this study. In general, I think including patients and including congenital heart surgeons and congenital cardiologists in the conversation as a new part of the heart team will be important as we plan for upcoming prospective trials.
Two major findings in your study. One was that the use of mechanical valves was protective in terms of mortality. I think that's a very important finding. Do you think the pendulum has swung forward too much and we should go back to using less bioprosthetic valves, and we're basically using too many tissue valves and we should think about using more mechanical valves? That's the first question. The second question, what was protective or what was a factor of mortality was the use of small prostheses. And so the question is, do you think we should be more aggressive in annular enlarging procedures as we do these procedures?
Thank you. As I mentioned, we do show a potential survival advantage with mechanical valves. So I would not necessarily abandon. Your question was about bioprosthetic valve use increasing?
No. Should we use more mechanical valves in young patients as opposed to tissue valves, which is the current trend? The tissue valves are the current trend.
Yes, exactly. No, I think that mechanical valves here show a survival advantage and are still a good choice.
So we should maybe think about using them more.
Yes. To answer your other question about annular enlargement, although I showed the inverse relationship on our slide, in our multivariable models for mortality and morbidity, there was an increased risk of mortality and morbidity with each millimeter decrease in the implanted valve size. But the short answer for now is no, as far as adding more annular enlargements. Not only does it increase your cross-clamp time, which comes along with a permanent increased risk of morbidity and mortality, but I think that the problem with small prosthesis in adults is related to patient prosthetic mismatch rather than just the size of the valve, and there's been a large body of work to support that. Because effective orifice area differs by manufacturer, we did not attempt to analyze patient prosthetic mismatch in this study. Also, we did not further define the incremental risk that is associated with annular enlargement. But in a recent study by Drs. Hawkins, Alawati, Mark Joseph, and others, they showed a nearly twofold increase in the risk of operative mortality and complications with the addition of an annular enlargement.
Great. Thank you very much.
Basha.
I think we have time for one additional question. Please identify yourself.
Chuck Fraser from Austin. Dr. Nelson, thank you for an excellent presentation and really telling us what's going on real time. As you very well know, there's an ongoing debate and evolution about what are the most meaningful outcomes measures for patients with congenital heart disease. So your study, of course, is really telling us what's going on in the acute setting. But I can imagine that we're going to need to know, if you're a young person who has a TAVR with other complex congenital heart disease, what's life like for you going forward? And so I would just be interested in your thoughts about how we're going to do that, how we're going to know that. And we've got this opportunity with the new evolution of the database, but we really need to know what's going on with these patients a year, 5 years, 10 years from now, because in the congenital world, of course, we're measuring our outcomes in terms of decades.
Exactly. Thank you very much for your comments. I think it will be extremely important to incorporate a quality of life measure into a planned prospective trial so that we may understand over time the impact of TAVR potentially on those factors. I think that there is a great appeal and an allure for TAVR for younger patients given the anticipated faster recovery time, no scar, and short hospital stay. However, if it leads to increased numbers of repeat interventions or salvage surgery, that'll be important to recognize. So I think the most important thing to focus on is including congenital heart surgeons and cardiologists in the conversation early to plan out these trials responsibly. So I think bottom line, the heart team needs to expand. Thank you.
Thank you.
Great. Thank you very much. Great. Please join me in congratulating our Chamberlain presenters and discussants. Really outstanding papers. So it's time we're going to take a short break. There'll be complimentary coffee and some New Orleans treats in the exhibit hall next door. We hope that you'll have a chance to visit with the exhibitors and browse the electronic posters. Also, stop by the STF booth if you have time. And again, ask about membership if that's an interest of yours. I also want to, a couple of good housekeeping issues. Want to make sure that we have a business meeting this evening, and then immediately prior to the business meeting, we'll have the Thomas Ferguson Lecture here in this room, where Dr. Domenico Pagano from the United Kingdom will present Make Evidence Great Again. So it looks like it's going to be a stimulating morning and afternoon, and we ask you to be back in your seats at 11 for some sort of an address. I'm not sure what it is. Thank you.